Hi, I'm Jeff CRNA. I was going to give a brief talk on some basic airway equipment. By no means is this meant to be a comprehensive list of the different type of airway equipment that you'll use, but this is the airway equipment that we have here at our surgery center. So we're an ambulatory surgery center. We do outpatient surgeries. We are multi-specialty. We do a lot of orthopedic cases here, a lot of ear, nose, and throat cases, podiatry, gastroenterology, general surgery, urology. But basically, some of the things that you're going to see when you go to your various facilities and in your training program, for those of you that are going to CRNA school, first of all, Laryngoscope Handle, basically very simple. This is kind of a normal size Laryngoscope handle that we would use in adults. They do make one that's about half of this length. Sometimes we'll use those in larger patients because it gives us a little bit more room when we're dealing with the patient's jaw and their chin and their chest. But just so you know, this is usually the typical Laryngoscope handle. Now the Laryngoscope blades, there are many different types, but I would say 99% of the time you're going to be using a Mac, which is a curved blade, or a Miller, which is a straight blade. And I would say typically for most adults we would use what is known as a Mac 3 blade, and this is what a Mac 3 blade looks like. And you're basically just connecting your Laryngoscope handle to your Mac 3 blade and verifying that you have a light there. Notice this little ridge on the Mac 3 blade, that actually goes into the vallecula when we're intubating a patient. And I'll show you a little drawing of that here in a minute. But the vallecula is a spot at the base of the tongue. And when you put this in the vallecula and kind of push in and lift up, it lifts the epiglottis off of the trachea and gives you a good visualization of the cords. Now this is the curved Mac 3 blade. There's also a Mac 4 blade, which is just a little bit longer. So in a patient that might be a little bit taller or a little bit deeper, we would have a Mac 4 blade as compared to a Mac 3 blade. So it just allows you to view a little bit deeper here. So those are the Mac blades for an adult. Again, they come in various sizes. And those are curved blades. We also have straight blades. There's several different types. There's a Miller type, there's a Phillips type. Basically, I'm going to show you the Miller type. And this would be a Miller blade, which is a flat blade. And I would say it really comes down to the provider choice and what you get comfortable with in your training. But I would say that in pediatric cases, a lot of people feel that the straight blade or the Miller blade is preferable because children have a larger floppy epiglottis. And sometimes when you're using the straighter blade, it allows you to actually lift the epiglottis off of the trachea, helps you see a little bit better versus the Mac blade. So when you're in your training programs, you might notice that you're going to be using straight blades more than curved blades when you're doing pediatric cases. So once again, they come in various sizes. This would be a Miller 2, and we also have a Miller 3 blade here, which is essentially the same thing, but just like the Mac 3 and 4, it just has a little bit more width to it. So you can see the difference here between the Miller 2 and the Miller 3. You can see my wonderful drawing here on this board. What I'm trying to show you here is if this was a cross section of the tongue, so this is the front of the tongue, this is the back of the tongue kind of curves around in the posterior oral pharynx, and there's this little gap in here called the vallecula. So this is the vallecula here, and the epiglottis is this flappy piece of tissue that actually covers the trachea here. So this is the trachea in red. So when you actually breathe, the epiglottis lifts up and you're able to bring air and oxygen down in through your trachea. But when you're intubating a patient, you're going to be bringing that Mac blade, which is the curved blade, along the base of the tongue. You'll be putting the tip into this area here called the vallecula. You'll be lifting and pushing up, and it's going to flip this epiglottis up so that you can see into the trachea. You would see the vocal cords down here, and that would allow you to put your endotracheal tube in the trachea. Now we're doing the pediatric cases. Obviously, we're going to be using a smaller pediatric laryngoscope handle. You can see that here. We also have a bunch of different types of blades, which are a lot smaller again. This here would be a Mac 1 blade. You can see how tiny that is. And obviously we would connect that to our laryngoscope handle and we would have our light there. So again, different types of blades. This is a curved or a Mac. This is a Mac 1. We even have, at our center, we'll do down to H1 here. But here I have a Miller 0, which is a very, very tiny blade. But again, it's a Miller, so look how it's straight and it's flat here. Miller blade. And we also have a Miller 1 blade here. So here's our Miller 1 blade, and we can see the difference between the Miller 1 and the Miller 0 blade as far as they're both flat and straight, but really just the length of the blade. They make a bunch of other different types of blades, which we don't keep the other types here. They make a Phillips blade, which has kind of a little curve inside when you're looking to view down towards the vocal cords. They also make one called a Wisconsin blade, which is a type of straight blade. Wisconsin blade, which is straight, and this is a Wisconsin 2 blade that we're using. But if you notice, when you look down the phalange here, you can kind of see there's like a little bit of a bend or a little bit of a curve in the actual blade itself, so that when you're going down and lifting up the epiglottis, you can kind of view through this little side port here. So again, these are different types of laryngoscopes and laryngoscope blades, different size blades, and depending on the size of your patient, whether it's an adult or a child, will determine the type of blade that you would use. Also, again, the provider preference, which can't be understated. A lot of times you have people that have learned on a straight or curved blade, and they go their entire careers using that type of blade. My preference for me is I typically use a curved blade. I just feel like they're easier, they're great, easy to use. When I'm doing pediatric cases, though, I do tend to use the straight blade because I do feel like it helps me lift up the epiglottis and get a little bit of a better view. So just something to think about when it comes to laryngoscopes and laryngoscope handles. Now, in the last 10 years, something that has really a huge innovation in the airway world in anesthesia has been the use of video laryngoscopes. And there are several different types. Here at our facility, we use something called a CMAC, which is made by Carl Storrs, but basically it is a laryngoscope with a nice bright light here, but you can see how the cable is connected to a video source here. So what we can do is, if we have someone that has a difficult intubation, what we can do is use a video laryngoscope. We're going to place this inside the patient's mouth, kind of lift the tongue up, and as we're doing that, we'll be looking at the screen here for the epiglottis and the airway structures before we pass an endotracheal tube. Again, this brand is Storrs brand. There is another brand out there called the Glidescope, which is probably the most popular. And once again, these handles come in different sizes. This is a CMAC 4, which is a little bit larger. And we also have a pediatric CMAC blade. So you can just see the difference in the sizes of the blade here. And again, this is part of a video laryngoscope system, which basically allows us to intubate the patient if they have an anterior larynx or they're difficult to visualize. And the video laryngoscopes have really revolutionized anesthesia in the last 10 years, probably one of the greatest inventions. Before video laryngoscopes, what we typically used was a fiber optic bronchoscope, and I'm going to show you that here in a second. So the fiber optic bronchoscope is something that we could use in a difficult airway situation, but it's fiber optic, it's flexible, you can see it here. But what we do is basically the fiber optics allow us to look through the tip of this cable, and what we do is we pass this fiber optic through the endotracheal tube. And then when we're using the fiber optic, basically we're looking through the eyepiece, and we're using this trigger here, this thumb trigger, to manipulate the tip of the fiber optic scope. And then we have the scope, we either look through the eyepiece or we can connect the scope to a video source and look on the screen as we're guiding the tip of this fiber optic scope in through the vocal cords. Once we get past the vocal cords, we then would pass the endotracheal tube over the fiber optic cable into the patient's trachea. So this is another advanced airway device, and before video laryngoscopes, this was really the main way of dealing with difficult intubations. But now with the invention of the video laryngoscope, it has made it a lot easier. I would say, from my personal experience, the fiber optic scope is a little bit more difficult to manipulate in a patient's airway than using a video laryngoscope. I just wanted to remind you, what I'm showing you too is not a exhaustive list of the different types of airway equipment, but this is the airway equipment that we have here at our surgery center, and it is sufficient enough equipment that allows us to do our job here as anesthesia providers. I will say that at a lot of facilities, the ones that I've showed you, the laryngoscopes and the blades, these are all stainless steel and they're reusable. So after they're used one time on a patient, they are sent to be sterilized and brought back to us to be reused. Now I know that at some facilities, they have disposable laryngoscope handles and disposable laryngoscope blades that come in different sizes, and they're one-time use. People use them and they throw them in the trash when they're done with them. So again, this is not an exhaustive list of airway equipment. This is just the airway equipment that we have in our facility. Some other basic airway equipment that you may see, or you will see for sure, I can guarantee it, once you get into CRNA school, are OPAs, which are oral pharyngeal airways, and MPAs, which are nasal pharyngeal airways. They also come in different shapes and sizes. I could say that this would be a oral pharyngeal airway or an OPA, and the ones that we have at our facility are made out of a hard plastic, and they have actually a empty space inside. It's actually hollowed out here, and basically when a patient has an airway obstruction, you can place this oral pharyngeal airway inside their mouth, and you're gonna, when you do this, you want to measure from the corner of the mouth until the angle of their jaw to know that it's appropriate. This is an 80 millimeter oral pharyngeal airway, but these are great for getting the tongue out of the way and relieving an airway obstruction. They come in various sizes. Different manufacturers make different ones. These are the ones that we have at our facility. We have little pediatric ones too, real tiny. And there's also something known as a nasal pharyngeal airway, which is made out of this silicone. They come in different lengths and different thicknesses. But basically, when someone has an airway obstruction, you could place this oropharyngeal airway into the nose. You basically go straight in, and then this would go in the back of the pharynx, and then that would actually relieve the airway obstruction. So oral and nasal pharyngeal airways, very common airways that are used in patients. Next, I want to talk to you about another fantastic invention. It was invented by Archie Brain, who I believe was a physician anesthesiologist in England. I want to say maybe in the 80s, but something known as a LMA, or a laryngeal mask airway, okay? And these come in many different shapes, many different sizes. They make disposable ones, they make reusable ones. A couple different manufacturers that make these LMAs, but it's known as a supraglottic airway device. Now, this LMA happens to be a size 4, which is a pretty common size in an adult. And when you look on there's side markings that tell you basically, so on a patient that's 50 to 70 kilograms, this would probably be the appropriate sized LMA to place in them. These are very, very simple. Again, it's a supraglottic airway, and these are the reusable ones. But basically, we deflate the cuff on here, made out of silicone, very soft, and we put a little bit of KY gel or lubricant on the LMA. We then place this down past the tongue in the back of the trachea. It kind of rests just behind the tongue. Then we can connect this to our breathing circuit and ventilate the patient. This is an LMA number 4. This is known as an LMA Classic. And again, it's reusable, so after each patient, this also gets sterilized by somebody and packaged so we know that it's able to be used again. These come in various sizes, and this would be an LMA 4. And this, just for comparison's sake, this is a little pediatric LMA, and this one is an LMA size 1, I believe. I believe this is an LMA, yeah, it's an LMA number 1, I'm sorry. So this little LMA is an LMA number 1. And once again, if you look at the markings on the size, let's see. This would be used in an infant under 5 kilograms. So again, notice the difference in size between the LMA 1 and the LMA number 4. I know that we go up to a size LMA number 6 at our facility here. And I believe the LMA number 6 goes in patients that are greater than 100 kilograms. They do have a little pilot cuff here that you inflate when you place the LMA. This would be a disposable LMA. You can see how it's made out of plastic. This is a size 4. And just like the reusable LMA, you would use this little pilot balloon. You would deflate the air out of this. You'd put a little bit of KY jelly on the back, maybe a little bit on the inside, and just place this LMA in the back of the oropharynx and connect your breathing circuit to the tube here. So again, this is a disposable type LMA. We also carry something known as an LMA Supreme here. And with an LMA Supreme, basically you have your, when you connect the circuit to this big round area here on the LMA Supreme, it allows you to ventilate the patient through the LMA like a normal LMA. But the unique thing about the LMA Supreme is that it has a gastric port on it. So you see this little extra port. You could place a small NG or OG in this little hole. And when you do that, it's going to come out this little hole that's at the tip of the LMA Supreme. So when you place this in the back of the patient's oropharynx, and this is sticking out of their mouth, the OG tube could go down here, come out the tip here, and go into the patient's esophagus, into their stomach. And you actually could drain their stomach, and you could ventilate the patient through the ventilation hole here. But again, this would be known as LMA Supreme. This is also a disposable product, and we do keep these here at our surgery center. So there are multiple different types of LMAs. There's an LMA that's called a eye gel that a lot of people use that has a different manufacturer. There are other types of LMAs or supraglottic devices. Again, this wasn't meant to be a comprehensive review of airway equipment, but I just wanted to give you a brief talk about some of the airway equipment you'll see when you're in school, and I hope that it gives you a head start. So I hope that's helpful. Study hard, and good luck to all of you that are applying for CRNA school. I wish you all the best of luck. Thanks.